Patient is a diabetic, hypertensive, CABG almost more than 20 years back, ICD with anginal chest pain and rest dyspnea with acute coronary syndrome. Troponins were raised and hypokinesia in inferior posterolateral and anterolateral area and increased mitral regurgitation, and there was obstruction of Svg graft was suspected, and coronary graft angiography was done, which shows critical proximal lesion of SVG to PDA graft and occluded SVG to OM. Patient was advised PTCA to SVG to PDA graft. This was a native angiogram, no LED, only ramus was filling. RCA mid segment 100% occluded. And this is the SVG graft showing a very tight 95% lesion, negative shadow in the lesion, and lot of calcium. And the Lima to LED was patent. We decided to do a SVG graft angioplasty. The challenge was cannulating the SVG graft, multiple catheters. Then we used AR1, and we used the stiff wire to give a shape to the AR1. And you can see that we could mold the catheter and engage the SVG. And with so we took a balloon BMW wire, tried to take a 1.512 balloon which could cross the lesion. We tried to dilate that. We tried to go with a bigger balloon that was a 3x12, but it didn't give up. You could see there was a vest at the lesion site. Lesion didn't open up very well. And here we did a IVUS, and you can see there was a 360-degree arc of calcium, where nodules and the superficial and the deep calcium which was seen. So in view of this superficial and deep calcium and almost the luminal area less than 1 millimeter square, we decided that we will do a rota. We used a 1.5 millimeter burr at 1.8 like RPM. We did a 3 runs with a polish run with a rota. And we could achieve a good luminal area. So we went with a 3.512, dilated the lesion again with an NC balloon at 14 to 18 atmosphere pressure. And we took a 4 by 18 millimeter stent. But again, after deploying the stent, there was some waste in mid part of the stent. So we took a 4 by 8 balloon to post dilate the lesion. This was again the 4, we upgraded the 4.5 balloon, dilated at 14 atmospheric pressure. And that's what we achieved a good result in the SVG graft with the calcification. And the post-IVUS imaging, we could achieve a good MSA of more than 9.65. Proximal and the distal very well, stent was apposed well. So basically, whenever we take a patient of SVG graft, I think the lesion analysis becomes important in planning the procedure. Proper guide catheter selection with adequate support is essential for smooth and uneventful procedure. Here, the hard end of guide wire, we could use it to get adequate support and catheterize the SVG graft. And as the undilatable lesion, it was important that graded balloon dilatation should be done. Here the IVUS really helped us in planning the lesion modification with rota ablator. As SVG graft was more than 20 years old, it was completely arterialized calcium, and when we say that the 18 years old SVG graft, it is arterialization of the graft occurs, and that's why we could do a rota ablator successfully. Initially we thought the negative lesion, patient coming with a unstable angina and the tropi positive, it could have been a thrombus in addition, but it was all calcium on the imaging. And as SVG grafts get calcified over the period of 15 to 18 years, rotablation of SVG graft can be done with adequate assessment of lesion. And after lesion preparation by rotablation and adequate dilatation with non-compliant lesion, high pressure post-dilatation of the stent is important for proper stent expansion. And this is how we could do the SVG graft stenting with the rotablation and the post-dilatation. Thank you.